Good afternoon. I'm trying to make a presentation on a difficult subject about which all of us know a great deal already. When dealing with neurotransmissions and also how neurotransmitters act in trying to help patients suffering from various kinds of disorders relating to depression and anxiety or mixed condition, it is first important to know the mechanics of neurotransmission. So we would then know how best to apply various forms of treatment, including pharmacotherapy in the control of depression. So as I share the screen of the title with you and the supporting slide presentations, my image will become miniaturized, and hopefully you'll be able to find it in case you want to look at it. Thank you. So here goes. So we are going to deal with depression in adults, and I've relied on updating sources as mentioned here. The biggest updating source which guides us but not instructs us is National Institute of Health and Clinical Excellence. And they have already published a detailed guideline about depression, what causes it, what manifestations are, how to make a diagnosis, and how to treat such patients. There may be some repetitions and some priming information that you might care to see in an earlier webinar that I have produced. And this is entitled Depression, Psychosis, Schizophrenia. So here we go. First of all, let's concentrate on neurotransmission. This is a neuron, typical in the central nervous system as well as the peripheral one. And it comprises some long single branches, and there is a nucleus here, and this is axon. And of course, some of these axons divide into various branches, which are dendrites. But either as an axon or as the end of the dendrite, there is an end terminal, and then there is a gap called synaptic cleft, followed by a similar set of pattern of the neuron next to it. So this is how we understand that an electric potential arrives at one part of the axon, traverses through the main body of the neuron, and then, of course, it progresses along the axon. And then eventually it reaches the terminal of the dendrite or terminal of the axon. So how does it travel? It initiates initially as change of the electrical potential, sodium going out, potassium going in, aided by calcium influence. So there is a voltage produced, and the neuronal electrical impulse continues on up to this point. Let's look at the axon terminal synapses and what happens then. So this is a neuron. This is a primary axon, which has a terminal at the end with a cleft in between. And then there is a corresponding neuron. And so that neuron has receptor cells. And so therefore, the electrical impulse discharges chemical neurotransmitters, which traverses through the cleft and then reaches the postsynaptic terminal and then influences the chemical status and reproduces an electrical potential which goes on. So in this case, axon of one neuron is connected to the axon, to the dendrite of another neuron. So it's an exodendritic synapse. Similarly, there is an axon to the body of the neuron connection, exosomatic, and there is an axon connected to the axon. So there are numerous ways where an adjacent neuron connects up with its fellow. This is the presynaptic axon. And so as you see enlarged, it ends into a kind of a terminal. And within this area, which is the terminal part, there are vesicles present. And these small blobs are neurotransmitter chemicals of one kind or the other. So all of the neurotransmitters in this vesicle are likely to be the same, but not necessarily the other vesicle or the other vesicle. In other words, the presynaptic terminal will carry a variety of neurotransmitters lodged in individual vesicles, and there are many. They float into the jelly-like substance in the vesicle, so therefore they come either electrically attracted to the end of the membrane of the presynaptic axon, or they fall by gravity, or if there are too many vesicles, they will push one another and go down this way, one vesicle pulling the other one down. There is a synaptic cleft, which is well defined in terms of its diameter, and it is filled in with numerous vesicles which go in more or less through a channel which promotes their descent away from the presynaptic axon to the cleft. And so this is now packed not necessarily with one kind of vesicle containing a certain neurotransmitter, but others. So this cleft becomes saturated, and each vesicle, when it breaks, discharges its neurotransmitter here, and these would be picked up by the appropriate specific receptors. It follows that if it is a abundant vesicle with a particular kind of neurotransmitter, at its exit and control and then presence in the cleft, it will pack up the cleft until it is forced to either forcibly find similar receptors, or may try to squeeze into the other receptors, or it may just come out somewhere, either this way or that way. But as it is saturated and packed, and if it is not being used actively in a sufficient volume, then the neurotransmitter chemicals are picked up as a form of reuptake. So it comes back to the presynaptic terminal, and there it is assembled back into a neurotransmitter which could be squeezed into a particular vesicle. So there is recycling. When the receptor in the postsynaptic part of the axon or dendrite receives the vesicle liberated chemicals, it goes on and produces an electrical discharge. And then this travels forwards into the postsynaptic axon or dendrite, and then continues to complete the cycle. Looking at this is a neuron, nucleus, and an axon. If it were to float freely, it will be damaged by adjacent neurons, dendrite, or other intermingling parts of the central nervous system. So it's covered by a sheet. And so therefore, this is myelin sheath. And then the axon, which is well protected, goes on to connect up with the postsynaptic axon or dendrite after crossing the cleft. So if we want to a certain neurotransmitter to not collect up here, we can use a reuptake inhibitor. And similarly, there are others which promote diffusion. So we can manipulate various kinds of neurotransmitters into reducing or increasing the level of activity in the postsynaptic axon or dendrite. Now, we can group neurotransmitters from a functional, pharmacological, and disease-based treatment variety. So there are some neurotransmitters which produce adrenaline-like reaction if the neurotransmitter has adrenaline in it, or epinephrine. And so these are used for emergency use in fight and flight and increase the cardiovascular activity. Norepinephrine, it is specifically more involved with concentration, maintaining attention, and also it is to create a response to a challenge. If there is dopamine, which is allowed to function as a neurotransmitter into the postsynaptic neuron, then it produces happiness, such as reward from undertaking addicting drug, and therefore it can produce euphoric manifestations. Serotonin alters mood, so lack of it produces depression, and excess of it is the other way around, and it reduces and is influenced the activity and is provoked by light, and it makes one sleep more than function. Similarly, gamma aminobutyric acid, GABA, has a calming, sort of restricting activity, and it improves focus. It also allows for better control of motor activity. Acetylcholine, it is linked more with learning new tasks, having normal thoughts, or lack of it would produce thought disorder. It affects recent memory. And in addition, it also affects the motor functions of the muscles. Glutamate, which is the most abundant neurotransmitter in central and peripheral nervous system, is related more to memory. And so glutamate affects short-term memory as well as long-term memory. And it also affects new learning. There are some other transmitters, such as endorphins. And these are chemicals which cannot be fitted into these groups, but it produces euphoria and offers and improves pain control. When someone has exercised, it's the endorphin, which is endogenously produced, which offer comfort and relaxation after a phase of intense activity. So functionally, a neurotransmitter could be excitatory. And so being excitatory, it accelerates transmission and physical and mental activity. And so there are some neurotransmitters, the behavior of which is inhibitory. That means they slow down the transmission and reduce the concentration of those agents which cause depression. So excitatory neurotransmitters we know of as epinephrine, norepinephrine. Inhibitory neurotransmitters we know of as GABA, endorphins, and these are produced by the pituitary and hypothalamus. There are some modulatory neurotransmitters, and these are accelerants, and that potentially stimulates the activity of an existing neurotransmitter in place. So whether it is an excitatory neuron which is exposed to a modulatory neurotransmitter or an inhibitory, correspondingly it will accelerate and magnify, and principally it would involve many neurons at the same time through this activity. And the example of that is serotonin and dopamine. Some neurotransmitters can be both excitatory and inhibitory at the same time. Now we look at the pharmacological aspect of the neurotransmitters. So those which come under the group of monoamine reorganizations, the examples are serotonin, epinephrine, norepinephrine, and dopamine. Beginning with serotonin, it's a neurotransmitter which acts also like a hormone. It is made in the bowel linings and some specific cells and cells near brainstem region. They are basically inhibitory. And if the person has excitation which is predominant, then it reduces it or it stops it. If someone has low levels of serotonin, they would be having depression, fatigue, suicidal tendencies, or anxiety. In this aspect, excess production of serotonin can lead to serotonin syndrome. And this can be caused by drugs, agitative actions, and it produces hallucinations or the active aspects of psychosis, confusion, and even death. Epinephrine is a neurotransmitter which acts also like a hormone, and it's also known as adrenaline, and therefore it is manufactured usually by chromaffin cells or in the adrenal medulla. It's an excitatory transmitter which has cardiovascular activity and enhancement with bad results as well. If the level of epinephrine reduces, there is reduced excitement, poor reaction to challenge, and reduced stress response. Norepinephrine, noradrenaline, is usually present in the brainstem cells and also in hypothalamus. It is principally excitatory, fight or flight, and it peaks at stress and its level reduces during sleep. Its functional targets are cardiovascular, and it does produce anxiety in excess. Reduction produces anhedonia, energy, and psychomotor retardation with depression. Dopamine. Dopamine and acetylcholine were the neurotransmitters which led to many other research relating to other neurotransmitters. Dopamine is produced in the substantia nigra, brainstem, and hypothalamus. It is both an excitatory and inhibitory transmitter and also acts as a modulatory transmitter. The effects are such as those people who have received reward. It affects motivation and it leads to addiction. Increase of dopamine may lead on to competitive unnatural behavior, aggression, and social inhibition, leading to gambling and addiction. Some addictive drugs can increase the dopamine level. It also affects muscle coordination. Reduction of dopamine leads to features of Parkinsonism. Amino acid-based neurotransmitters are GABA and glutamate. GABA is primarily an inhibitory neurotransmitter produced in hippocampus, thalamus, basal ganglia, and also brainstem area. Reduction or lack leads to poor impulse control, seizure, mania, or insomnia. Excess leads on to tiredness and excessive sleep. Glutamate is the most abundant neurotransmitter in CNS and peripheral nervous system, is produced in most parts of CNS, is present in neuron glia, and is excitatory in nature, involved with cognition and retention of memory. Its lack leads to poor memory, dementia, Alzheimer's disease, epilepsy, psychosis, and reduced concentration. Excess leads to excitatory and neuronal death. This is toxicity of the excitement. Peptide-based neurotransmitters are endorphins. They are made endogenously by the body, and they act like morphines. So they are obviously inhibitory, made in hypothalamus and pituitary, and from tired muscle endings. It lowers pain signals and may also produce euphoria, leads to addiction, and the excitatory part of the patient's neurochemistry leads to cognition and memory, and this is affected by endorphins. Purine-based neurotransmitters. Examples are ADP and ATP. So adenosine diphosphate inhibits arousal and it involves sleep. And it is produced in the presynaptic hippocampus, and its shortfall or reduction leads to insomnia, headaches, and anxiety. Its excess leads to hyperesthesia, heat intolerance, and adenosine triphosphate is present in CNS and in peripheral nervous system, purine-based, and it controls autonomic control. It also is reflected in the understanding of sensory transmission and glial transmission. Acetylcholine cannot be fitted into the groups that I have just mentioned. And therefore, because it controls parasympathetic system, it therefore is related to the activities of muscle movements, memory, and learning of new tasks. Reduction leads to difficulties with learning new tasks, recent memory, dementia, Alzheimer's disease. Its excess leads to hypersalivation, myasthenia, vision problems, and paralysis. So we now come to clinical aspect as to how we diagnose someone has got depression. International Classification of Disease has suggested that in a continuous 2-week period, if the patient has depressed mood and diminished interest in activities for most of the day, nearly every day, then if they are accompanied by 1 or 2 or more of additional symptoms, which I have listed here, then that person is said to be suffering from depression. So this is self-worth, self-blame, recurrent thoughts of deaths and doom, sleep disorder, anorexia, and being tired all the time. The diagnostic and statistical manual has suggested that if someone has 5 or more symptoms in the list of 8 within the same 2-week period, where the symptoms are present most of the day, then they are suffering from depression. So this is the list, and you well know these. It's suicidal ideations and thoughts of deliberate self-harm. The clinical diagnosis, in summary, means that there is absence of a positive effect, such as loss of interest and enjoyment in ordinary things, low mood, and a range of associated emotional and other behaviors. If there is negative factors which leads to personal and social functioning, and with recycling of rumination, such as reminiscing and constantly talking about a past or something like that, then this is definition of a clinical definition of depression. So you see a patient that you suspect is suffering from depression. So asking and documenting three things. Have they felt sad, down, depressed, or hopeless? And that they had little interest in doing routine things which they used to do, but now in the last month, they have not got the same energy to do such things. And that such a feeling of depression could come in the morning, during the daytime, during rest, during activity. So if there's variability, so current sadness, lack of enjoyment, hopelessness for the future. So these are the things which need to be documented, in addition to relevant triggers which can initiate, cause, or worsen, or bring out from remission into relapse, a depression. So you know all these: past history of depression, bipolar feeling, how they responded to a given treatment, whether they can function properly with activities of daily living, what their relationships are like with those that they are close, what sort of lifestyle they have, whether they are obese or adopting healthy diet or indulging in alcohol more than recommended 14 units per week, or smoking, nicotine, and also using drugs of pleasure, social drugs. They also relate to what they achieve when they have physical and mental trauma and then they exercise. You need to do a risk assessment at this point, having diagnosed depression. So the risk assessment basically leads to identification, and by checking with the patient, suicidal ideation and intent, which is how have they planned something, the manner of committing suicide. Similarly, thoughts of self-harm. It is now a requirement for primary care when they diagnose depression in a patient that they must review the situation within 2 weeks' time of any suggestion, treatment, advice, or talking therapy. We must also see whether at the present point in time the patient has adequate help, social support, and knows where to contact for such help. If the suicidal risk is fairly high, this needs to be referred urgently to mental health team on the same day. If the risk was earlier, like on the previous day or in the previous week and not today, then they need to be urgently referred to the crisis intervention team of the mental health. Remembering that most patients with depression are more vulnerable at the time of leaving the hospital on being discharged, or when their medication is changed. There is a guideline from NICE which suggests we should not withhold treatment for depression on the basis of their suicidal risks. So we can take measures. For example, if the suicide risk is high and the person is waiting for the urgent appointment on the same day, or not that much high but substantial, and awaiting contact from the crisis intervention team, we should give in a limited supply which is safe, and we should have it administered appropriately in line with daily supervised medication, prescription to the chemist limited to 3 days or 7 days, and review thereafter. So let's look at exactly what happens when someone has depression from the point of view of functions as well as physiology. Nutt is a great psychiatrist, and he found and showed that a relationship exists between three main monoamine neurotransmitters and some specific symptoms. These are dopamine, norepinephrine, and serotonin. And that many well-recognized symptoms are associated with increase or decrease of these. As such, one can make a symptomatic diagnosis of what to use. Serotonin is associated with mood. Too low level is associated with too little enzyme manufacturing serotonin molecules, or either that when it is in the synaptic cleft, discharge from the vesicle, the unused or excess of serotonin is not taken back again, or that the postsynaptic terminal of dendrite or axon doesn't have enough receptors, so it is not utilized and still keeps getting secreted. So when dealing with a patient that you are going to prescribe medication, you need to obviously take care of allergies, over-the-counter use of, say, St. John's wort and other herbal medication, previous response to prescribed medication, whether these will affect his other comorbidities, explaining that some medications which have functions on neurotransmitters may be effective after 2 or 3 weeks, whether they will seek support from family or social services, whether they are taking the medication regularly and complying, and that they are aware of potential side effects. They should also know what to watch out for, and they should come back to the prescriber's follow-up in about 2 weeks' time. In the NHS, 2 weeks review after medication is necessary. It's also important to explain that if they have used the neurotransmitter affecting medication and they've taken it for a few months and feel more or less normal, from that point in time, they must continue taking it for another 6 months to prevent relapse. So there is a list that you can read subsequently of many antidepressant medications. So we're talking about SSRI. Examples are citalopram, fluoxetine, escitalopram, sertraline, and so on. So these are SSRI. There are SNRI medications as well, such as duloxetine, venlafaxine, and of course, others which have come up since then. There are some atypical antidepressants, so such as bupropion and obviously mirtazapine and trazodone and vortioxetine, which is newly marketed. These are atypical. Then there is the old-fashioned tricyclic antidepressant, imipramine, nortriptyline, amitriptyline. And so these are well known to produce some side effects and interact with other medication. Monoamine oxidase inhibitors are second line. Their use has reduced, but they are working fast to produce the desired level of actions and improvement. Phenelzine and so on are the examples, and there are strict dietary restrictions on not having cheese or something else which could potentiate or stop the function of Mayo with disastrous consequences. So SSRI are indicated for depression, anxiety, PTSD, OCD, and phobias. And it works by blocking reuptake or from the synaptic cleft. Otherwise, there'd be a buildup. Side effects are many, and they affect most organs and the central nervous system. I've already mentioned about serotonin syndrome, which causes confusion, delirium, shivering, sweating, tachycardia, and hypertension, and myoclonus. And so, of course, the risk of serotonin syndrome increases when fast-acting antidepressants, old-fashioned type, are used, such as a combination of Mayo and SSRI. SSRI are used, say, when someone, these are used with great caution because of interactivity with anti-epileptics and all of these other medication. In this respect, legally under the DVLA, Drivers and Vehicles Licensing Association, which is a statutory government body which determines who should hold a driver's license for a car or, say, a heavy goods vehicle or a train or a bus, then they require seizure-free interval of 12 months if someone has been diagnosed with epilepsy and then without treatment remains well without an attack, or has been put on medication of a recognized nature by a neurologist for 12 months, and for some reason SSRI are given. So it can alter the threshold of seizures. A well-controlled patient may now have seizures. So if there is a change or addition to the anti-epileptic medication, then that person will need to wait for 12 months from that point in time to expect rewarding of another license. So interaction is with many medications, and in general, they are with psychotropic medication, cardiac medication, diabetes medication, and so on. SNRI are generally used when SSRI is not helping. And there is usually a protocol of how to wean off SSRI and introduce SNRI. We'll touch on that in a minute. Side effects are similar to SSRI with similar drug interaction. Tricyclic antidepressants, they have potential considerable side effects in most systems of the body. Social or illicit drugs. And so these are marijuana, and they contain tetrahydrocannabinol, and this interacts with and binds to cannabinoid receptor in the postsynaptic terminal. and it produces a relaxing effect and can also cause an increase in dopaminergic activity. Heroin binds to the opioid receptor and also can release high levels of dopamine. Quick tolerance develop, and addiction leads to crimes, criminal activities, and gambling. Cocaine is a stimulant giving rise to a surge of dopamine released into the postsynaptic terminal and causes cardiovascular acceleration, but this excitation doesn't last very long. Ecstasy, it stimulates many aspects of problem, and it leads to often combined positive A type of symptom. If you want to switch antidepressants, then the NICE has recently given a guideline. So you need to gradually reduce over 5 or 6 weeks the initial antidepressant. And then at the same time, you will, when you have reached that level, you may have to alter the dose of your other medication, which could be a psychotropic drug. So you taper what is being given already. When you start the new medication concurrently, you start with a lower dose. And this is something which you will see in the original document, but I will show you that. So this is the original document published recently by NICE. And so it explains in practical details as to how you switch a patient from, say, citalopram to escitalopram, or from SSRI to SNRI. So it explains the reasons and the technique, and then you could obviously follow it up after discussing it with the patient. So it's expected to give you a guideline based on research. So it is very useful because you will know what the patient is on, and the patient needs to be changed to something different, and you know how to stop one and how to start with a lower dose next. There are also occasions when using the same class of antidepressants, you may switch without any weaning. Just stop one and start the other one at similar dose and potency. So all of these are now mentioned here, and then you could look at it from internet at will. Coming back to where we left off, so psychological therapies have a powerful role for mild depression when the PHQ-9 assessment is less than 16, then you could utilize talking therapies instead of pharmacological agents. Not all of the specific CBTs are available in each area. However, one needs to know the value of non-directed counseling, directed counseling, encouraging patients to work out why they have depression, accept the diagnosis, and they should themselves work out the remedies. This is in line with Pendleton's consultation style, and it works better, and it offers quick benefits. My explanation to the patient would be that tablets would take a longer while. if one could improve on your coping abilities, you'll be able to cope better and feel better, even if the stresses were to persevere. There are alternative therapies such as ECT. And obviously, there is now a reducing use of ECT, and where immediate or almost immediate break from deep depression is needed, such as in postnatal depression, because the newborn child's health and life could be at risk, ECT is provided. Transcranial magnetic stimulation, for some patients who fit the eligibility criteria, can be done. And it involves putting in a coil against scalp, and this sends brief magnetic pulses to stimulated neurons and the neuronal synapses. Thank you very much. I feel that with pre-existing knowledge and looking at the references and working out what suits best for your patients, sharing information and remaining update were the ideas of this presentation, and I hope that you have achieved these. Thank you very much for your attention, and we'll now leave one another in the thought that you will obviously make use of this presentation in a practical manner.